Call upon Dr. Leila Mohan Madam for her next talk on evaluating the cloudy cornea. Leila Madam doesn't need any introduction. She is the Chief Consultant of Pediatric Ophthalmology at Comtrust Eye Hospital, Kozhikode. Over to you, Madam.
Thank you, Dr. Suma. So, evaluation of a child with cloudy cornea. This is not an uncommon situation, the child being brought with either bilateral or unilateral white eye or opacification of the cornea. So, cloudy cornea is a challenging situation. We need to look for glaucoma, lens, whether it is cataractus, retinal pathology, optic nerve, the health of the nerve. Corneal opacity as well as cataract also can coexist in rubella and in many other conditions. So, multidisciplinary approach with cornea, glaucoma specialist, pediatric ophthalmologist and geneticist whenever possible should be there. And imaging the anterior segment gives clarity of what underlies the cloudy cornea. And urgent surgical intervention may be necessary in situations if it is glaucoma diagnosis is made. The old mnemonic stumped sclerocornea, tears, ulcers, mucopolysaccharidosis, Peter's edema, like in glaucoma and CHED, does not specify the underlying pathology. So now this is no more followed. The newer classification by Dr. Kenneshal is that primary corneal disease is specifically corneal, like in corneal dystrophy, cornea plana, structural pathology like dermoids and CYP1B1 abnormality, and secondary developmental corneal disease where there is an anterior segment developmental abnormality like anterior segment dysgenesis. It can be either iridocornelenticular or just iridotrabecular as in primary congenital glaucoma and aniridia, and the secondary acquired ones like mucopolysaccharidosis infective as in rubella. It can be there at birth also if the child acquired infection in utero, and trauma and non-infective cases. So the primary corneal disease like endothelial or CHED, which is the commonest. It is not so very common in our part. It is a rare condition. And posterior polymorphous dystrophy, corneal stromal dystrophy, endothelial dystrophy, many of them are have a better prognosis with keratoplasty, but the timing of surgery is again debatable considering the high rate of graft rejection and surgical challenges due to the low scleral rigidity, positive pressure and shallow AC in the neonate. And so the risk of amblyopia and nystagmus is also there when surgery is delayed. So all these have to be considered when taking up for surgery. So endothelial keratoplasty is the newer method in endothelial disease. So CHED is another condition which has to be differentiated from congenital glaucoma. It is rare. Consanguinity may be there and may present at birth or little later. Bilateral symmetrical blue-gray ground glass appearance from limbus to limbus opacification and with sometimes localized spots due to localized edema. And retroillumination, if the cornea is, the opacity is not so dense, can show the beaten copper appearance of the thickened decimates. And IOP may be falsely high also. So the other features have to be taken up for differentiating. Pachymetry is very high. It may be 2 to 3 times the normal. Corneal diameter is normal. No, the child doesn't present with the watering or photophobia or blepharospasm. So these are the features which might differentiate it from glaucoma. So keratoplasty is the way to go in these cases, and in congenital cloudy cornea secondary to anterior segment dysgenesis, they present with a wide vast phenotypic and genetic heterogeneity. Axenfeld, Rieger, Peters is the commoner one. Genetic analysis may be done if it is possible and affordable, and UBM or OCT will show the defect. UBM can be done under GA. OCT handheld is not available so freely, so sometimes it is difficult to assess the pathology under the corneal opacity. So often in Peters presents with the central corneal opacity with a little eccentricity, so sometimes we can do away with an optical iridectomy considering the challenges in PKP. So UBM findings in Peters will show whether there is an iridocorneal only or lenticular pathology as well. These are the three conditions which need to be differentiated at birth. The CHED, that is congenital hereditary endothelial dystrophy, Peters, and primary congenital glaucoma. So CCT is very, very high, 2 to 3 times in CHED. Corneal diameter is high in congenital glaucoma. In Peters, it may be smaller or normal, and iris thickness is normal in CHED. It is thin in Peters and congenital glaucoma. Hyperreflectivity can be seen in CHED, and in Peters you can see the adhesions between the iris and cornea, or sometimes even the lens may be adherent to the cornea. And the pattern of opacity, limbus to limbus corneal opacity in CHED. And the age of onset, sometimes it is at birth or sometimes a little later in CHED. So if we have the privilege of genetic study, then we know that SLC4A11 is CHED for 100%, we can make sure. Peters and PCG, congenital glaucoma, it may not, majority may show CIP P1B1 genetic pathology. So evaluation and detailed history is important. EUA may have to be done, and B scan will show any posterior segment pathology, and a cupping also can be sometimes made out in advanced cases. UBM gives good images of anterior segment in a clouded cornea, and linear ultrasound scan, which the anesthetist use for vein detector, can be used for assessing the anterior segment, because the handheld OCT may not be available. It is not usually very commonly available, and torch titer has to be done to rule out any infective pathology, and systemic associations may have to be ruled out, and laryngeal mask anesthesia is better, not ketamine anesthesia for an EUA. IOP may be high in falsely high. IOP better checked with Perkins. Slit lamp, gonioscopy, axial length, fundus for cupping, all these have to be checked, and a cyclorefraction definitely. Cloudy cornea with Habs ray, this is a child with already a tube there for EUA. You can see the double contoured breaks in DM. The picture on the right side is a tear during birth due to force of delivery. Congenital glaucoma with iridocorneal adhesions and partial aniridia, all these have to be followed up for increase in IOP, and a flying baby OCT as can be taken sometimes. It's not always possible. We can try. So primary congenital glaucoma has to be suspected when the corneal diameter is higher. For his age, at birth it is usually 9.5 to 10.5. If it is higher, you have to suspect. More than 12 millimeter under 1 year is definitely suspicious, and more than 13 millimeter at any age is highly suspicious. The axial length also has to be measured and followed up. A serial measurement whenever there is a doubt gives you a better idea. And cupping, any asymmetry between the cup, usually there is no cup in a child. So just want to say, this child was brought with bilateral opacity, UA was done, and during every case we do a scan to note the axial length. So when A scan was being done, we didn't see the lens spike. So UBM, again after that, this is the lower figure shows the lens spike. So we did a B scan and found that there is no lens there at all. It is a primary congenital aphakia, which is a very rare situation, but a very bad severe developmental anomaly. Vitreous is abnormal. Keratoplasty often produces very poor outcome with iris bulbi. So in these cases, imaging is very important to know whether the lens is there at all. And this child came with a white eye one fine morning with an acute eye drops. He had glaucoma. Glaucoma surgery was done in one eye, and later he came with the haziness and IOP high in the other eye also. Both eyes were operated. This Peters, we did B scan and found that there is no anterior segment pathology behind the cornea, but for a thinning of the cornea. So an optical iridectomy was done, and later refractive correction and patching. And I'm happy she has 612 vision, 618 vision at 12 years of age, with occasional divergence. Probably we might do a surgical correction for squinting later. So corneal dermoids are purely corneal. We can see them. An OCT may show they can be operated for lamellar or penetrating keratoplasty can be done. So it's important to diagnose a glaucoma and follow them up with serial axial length measurements. Not all opacities are to be labeled as sclerocornea because we need to know what is happening underneath. And surgical intervention when it is diagnosed is urgent. So the risk versus benefits of corneal transplant has to be considered and outweighed when considering surgery and discussed with the patient's parents whenever we consider surgery. Thank you.
Thank you, madam, for that wonderful talk.